Catholic University of Santiago of Guayaquil. We are going to talk about PFO closure for cryptogenic stroke, presented by Aislinn Alvarez Random, teacher Dr. Young Moscoso. Secondly, definition. Cryptogenic stroke (CS) is defined as cerebral ischemia of obscure or unknown origin. The cause of CS remains undetermined because the event is transitory or reversible. Closure with patent foramen oval endovascular devices (PFO) reduce the overall risk of stroke in patients with a previous cryptogenic stroke, according to the close and reduced trials.
Hello, my name is Shadi Reyes. I'm a intervention fellow at MidStar Washington Hospital Center, and with me is Dr. Lowell Sattler. He's the director of the cath lab at the Heart and Vascular Institute, MidStar Washington Hospital Center. Welcome, Dr. Sattler.
Thank you.
Today we're going to talk about the PFO closure approval. So in October 2016, the FDA approved the closure device, the Amplatzer, for cryptogenic stroke. Who do you think the ideal patients to be referred for this procedure?
So this was a major change in the concept of treating PFOs in patients who had had a stroke, because previously their data was never really clear to suggest that closing a PFO could prevent recurrent strokes. There were several trials. They all were in favor or leaning towards the benefit of closing the PFO to prevent strokes, but none of them really had the power to demonstrate efficacy. And then the last of the trials, which ran over 6 years, which was RESPECT, finally demonstrated at 6 years that closing a PFO was actually superior to medical therapy. Now, the patients that would be best treated are patients between the ages of 18 and 60 who've had their first stroke, who've had, after an extensive evaluation, no other obvious cause of a stroke short of having the PFO. Once they're identified, then we can talk to them about the risks and benefits of treating them and how we would treat them. There is a dedicated device now that we can use to treat PFOs and close them.
All right, so when they go through this procedure, are they expected to be on blood thinners when they discharge?
So we have them on whatever their antiplatelet or antithrombotic therapy is up to the procedure. Once we complete the procedure, we typically would keep them on dual antiplatelet therapy for at least 2 months. Now, if they had a deep venous thrombosis or they have atrial fib, or there's some other reason to keep them on a vitamin K antagonist or a NOAC, we would continue that and work that into the program. But generally, we just keep them on dual antiplatelets for 2 months, then drop the clopidogrel, and then continue the aspirinol.
And this is a same-day procedure. The patient comes in the morning, leave in the evening?
Yes, they come in. The procedure is done in the cath lab. It usually takes a little less than an hour to 2 hours. We perform the procedure with fluoroscopy and a technique known as ICE, which is intracardiac echo. And that's allowing us to get a better visualization of the defect by putting a little catheter on the inside of the heart and shining an ultrasound beam at the defect itself. Once the procedure is completed, they usually go to our holding unit and are discharged the following morning.
And there is no transesophageal echo?
No, the introduction of the intracardiac echo, or ICE, avoids the need for a transesophageal echo.
And the bay will be done conscious sedation, and the patient will wake up?
Yes, it's done under light sedation. And again, usually the patient is able to go home the next day.
And how long the patient should follow up with you or his primary cardiologist?
So we do watch them carefully for the first year. There is the remote possibility of device erosion. It's probably on the order of 1 in 10,000. So we do watch for evidence of some abnormality in the device eroding into the heart. Usually we get echoes at set times over the next year, and then that would be the completion of a follow-up.
So this is really exciting news for the people who suffer from cryptogenic strokes, and now at least we have a solution.
Yeah, it changes really the algorithms that we treat patients with cryptogenic strokes, because in the past, the patient would have a stroke, we would put them on medical therapy, and the only real indication for device closure is that they'd have to have another stroke. So a lot of them were terribly anxious because they were waiting for that second stroke. And this eliminates that by having a more effective therapy than medical therapy for the management or prevention of recurrent strokes.
That's really exciting. And we implanted the first one in the cath lab here at MedStar last week.
Yes, in a patient who actually, by chance, had had recurrent strokes and was thinking about having the closure, and then we got the indication, and the timing was right, so he was our first PFO closed.
Interesting. So at the end, I would like to thank Dr. Sattler for his time. He's, again, the director of the cath lab at MedStar Washington Hospital Center. And please, if you have any patient that fits the criteria that was mentioned by Dr. Sattler, please call the number down on the screen, and we'll try to help you. Thank you.
Thank you.
Application in medicine. There is now a consistency of the evidence showing that PFO closure does reduce the risk of recurrent ischemic strokes, and the risks related to the procedure and devices are small and mostly transient. Cons. Serious adverse events due to the procedure or device were infrequent, 4.4% in respect, 3.9% in reduce, and 5.9% in class. Atrial fibrillation was more common in the device arm of reduce, 6.6%, than respect 4.4% and clause 4.6%. Pro. One meta-analysis found that PFO closure was superior to medical therapy for the prevention of recurrent ischemic stroke.
Welcome to PCR TV 2018. My name is Simon Wilson. I'm a cardiology registrar from Edinburgh in the UK, and I'm here today with Dr. Miles Behan, a consultant cardiologist, also from Edinburgh, UK. So, Dr. Behan, can you please tell me about new data for PFO closure in cryptogenic stroke?
Certainly. So, just to start, cryptogenic stroke patients tend to be quite young. So, to prevent recurrent strokes is crucially important in these young people.
Yes.
However, previously, all the trials have consistently failed to show a benefit of device closure over medical therapy in these patients. However, recently, trials have been published which have challenged this. That the RESPECT, REDUCE, CLOSE and PC trials overall have shown that the risk of recurrent events in cryptogenic stroke patients is low, but is significantly reduced further by device closure.
Were there any complications with device closure?
Bleeding was the same in both arms, so there wasn't a significant increase in bleeding. However, there did seem to be an increased rate of atrial fibrillation in the device arms.
Okay. And were there any subsets of patients in particular that benefited?
Interestingly, the patients who benefited were those with a large intra-atrial shunt, that there didn't seem to be an effect of the presence of an atrial septal aneurysm.
Okay. Do you think, in light of this new data, should we consider device closure for all cryptogenic stroke?
I think that's a very good question. I think with this data now, I think device closure should be considered in patients with cryptogenic stroke. However, I think that we need to move to an era where we have a heart and brain team. With the very successful heart team for TAVI, I think we now need a heart and brain team which will have a neurologist and a cardiologist working together just to exclude other causes of stroke to make sure that we're getting the right patients. Sometimes a hematologist may need to be involved as well.
Is that something you put in place in Edinburgh?
Well, I think that's something that we're going to put in place because I think our practice is going to change and we're going to see a lot more patients being considered for this therapy.
Do you see in Edinburgh that numbers of device closure is going to go up?
I would have thought that it will in light of this data because these are a very important group of patients that we want to protect from further events.
Okay. Well, thanks, Dr. Behan, for summarising that. And that's EuroPCR 2018 for today.
Applied in Ecuador. At present, the Guayaquil Clinic and its Department of Hemodynamics and Interventional Cardiology have a program for the treatment of congenital heart disease by applying PFO closure for cryptogenic stroke, one of which is the use of devices such as implanter. And conclusion, in summary, PFO closure is of moderate benefit compared to antiplatelet therapy alone in the prevention of recurrent ischemic stroke in adults up to 60 years of age. It remains unknown how anticoagulation for the prevention of recurrent ischemic stroke